All right, the next topic we're now going to do is on the topic of biostatistics. I call it what are the chances? The key is understanding biostats to the point that you can actually use the information. You're going to get a lot of questions on USMLE that's going to ask you to analyze different studies, and you got to figure out what's wrong with it. Notice the important thing is knowing what's normal. So that's why I'm going to attempt in this video to show you how to understand the different definitions. That way, when they give you a vignette, you're able to understand what it is that they're asking of you. So, let me count the ways. Key definitions you want to know. Epidemiology is the study of the behavior of disease in a certain population. So notice it's population specific, because the epidemiology of disease in one state is not the same as another state. It's the same disease, but it acts differently in different populations. So epidemiology is very population specific. The next term, endemic, means what is the normal and expected occurrence rate of a disease. The endemic rate for a disease is the number of times you expect it per unit population. So maybe you need 5 cases per 100,000 people, 10 cases per 100,000 people. That means if the endemic rate is 10 cases, as long as you don't get any more than 10 cases, it doesn't grab anybody's attention. But now if you got more than 10 cases, then it starts to grab people's attention. Because the next term, epidemic, is when you have an occurrence rate of a disease that's more than 2 standard deviations above normal. This is what the CDC does for a living, tracks all of these occurrences of different diseases. Whenever there's an epidemic, it is their job to come into that area and find out what is going on. All right? A lot of times it may be just because there's an increase in screening, because remember, anytime you increase screening, prevalence goes up and incidence goes up. But you have to try to prove that there is nothing, has not been a breakdown in health care or health services to people. A pandemic is when the entire world is involved in an illness outbreak. Much like influenza virus. It turns out that about every 24 years, there's a huge pandemic. That means a virus jumps from being in animals to being in people, which means at that point in time, nobody has resistance to this virus. So that means the first wave of illnesses, a lot of people are expected to die until enough people have had the illness and built up immunity that now the virus does not pose any threat. So pandemic is when the entire world is involved. Key rates you want to remember. Most things are going to be over 1,000 live births, except a couple which are per 100,000 people in the population. So birth rate means how many live births, how many children are born alive per 1,000 pregnancies. Birth rate. How many children are born alive per 1,000 pregnancies. Fertility rate is how many live births are given in people of fertile age. Right now it's 15 to 45. So fertility, the term tells me, how many live births per 1,000 people in the fertile years. Infant mortality, the next rate. Infant mortality is how many people died during the first month of life. First year of life. An infant is 1 month to 12 months of age. So infant mortality is how many deaths were there in children aged 1 month to 12 months. Currently, the number 1 cause of infant mortality is SIDS, followed by child abuse. The next one is called neonatal mortality rate. Neonate is a baby 0 to 30 days of age, first month of life. So neonatal mortality rate will be how many deaths seen in children in their first month of life. So currently, the number 1 cause of neonatal mortality is prematurity, respiratory distress syndrome. If If you remember in pulmonary, we said it has about a 60% mortality rate. Then there's another term we can call perinatal mortality rate. Perinatal. Perinatal mortality would be number of live births in the first month of life, but you now include stillborns. Stillborn is any child who died in utero after 20 weeks gestation. So in the difference between neonatal and perinatal is that you add the stillbirths to the neonatal deaths. Maternal mortality rate and crude mortality rate are per 100,000 population. So maternal mortality rate just says how many women died during the birthing process. That means including the pregnancy. So how many women died during the pregnancy or birthing process per 100,000 population. And crude mortality just says how many deaths are there per 100,000 population. And there, it doesn't really tell you the cause of the deaths. Then case fatality, the next term. Case fatality takes the number of people with a certain case, you put them in the denominator, and in the numerator you put how many people actually died from that disease. So the fatality number goes in the numerator, the total number of people with the case goes in the denominator. So it tells you the case fatality. So on the boards, they'll typically give you a long list of diseases, and then they'll ask you one question: what is the case fatality rate for methicillin-resistant Staph aureus, let's say? All you do is go down that entire list and you'll see methicillin-resistant Staph aureus. And you'll see the number of people who died, that's your numerator, and then you add it to the other column, which is the number of people who did not die. So total becomes your denominator, and the fatal case is your numerator. All right, and the last key rate here is attack rate. What is an attack rate? Attack rate is the denominator, number of people who are susceptible, and in the numerator, number of people who actually got the disease. So the attack rate is based on the susceptible population only. It tells you how efficient an illness is, whether it's highly contagious, moderately contagious, or only slightly contagious, or maybe not even contagious at all. There are many ways to do a study. So we're going to discuss the many ways that you can actually do a study. Different studies. Number one, case study. This is when I, the physician, write up an interesting case because I'm thinking my peers may want to know about this. So maybe you see the weird presentation of a common disease, or you see the common presentation of a weird disease, or you just see a weird disease altogether. You write it up. Second term, case series. Case series is when somebody pulls a series of case studies. When you do that, what you're doing is trying to find a trend in these cases that you're seeing. That way you can find, is it attacking mostly children, mostly adults, mostly pregnant women, and so forth. It gives us an idea who the susceptible population is. Let's say we have a limited amount of vaccines, and then you need to find out exactly who you need to target first. So case series can help you. A cohort study is when you grab a group of people and you have an entry criteria about who can be part of that cohort. So cohort study is simply you have a group of people, you have to set up entry criteria and then limitations. It has to be well defined so that you don't have the wrong people in that study. Whenever you don't have well-defined criteria about who can get into the study, then you can set up what we call a selection bias. Selection bias is when your entry criteria is too wide so that you allow too many people who don't really fit the criteria for the group that you're trying to target. So let's say you're trying to do a study on heart disease. if you notice, most studies on heart disease exclude people above the age of 65. Why? Because it's normal to see heart disease after age 65. And so if you include people who are over 65 years of age, you're going to have the wrong population, and so you're going to overestimate the incidence of your problem. So cohort study can be either prospective. Prospective means you're going forward in time, and you're going to watch them to see what's going to happen. And when you do a prospective study, you're going to start looking for new cases, which is called incidents. So incidents are new cases, and then you're going to be looking for prevalence. Prevalence is total cases, and then at the end, you calculate a relative risk. So once again, whenever you do a prospective study, you're going to follow these people forward in time. You're going to be looking for new cases as incidents. You're going to be looking to calculate the total cases as prevalence. And then you look for relative risk. Relative risk is the chance of getting the disease after an exposure. So the chance of a heart attack if you have high cholesterol, that would be your numerator, over the chance of getting the disease without the exposure. So that, when you compare the two, then you get a relative risk. So let's say you tell me the relative risk is 5. You're telling me that that person is 5 times more likely to get the disease compared to the other population who have not been exposed. So that means the risk is very high. All right? So now if you tell me the relative risk is 5, you can also calculate a confidence interval, meaning how confident are you that the information you're giving me can be explained or attributed or relate to at least 95% of the population. Here's the rule. If your relative risk is above 1, then both your confidence interval numbers have to be above 1. If your relative risk is below 1, then both your confidence interval numbers have to be below 1. In other words, you cannot go across 1. 1 is the number ascribed to the general population, and there's no way you can say that your information can be applied to everybody in the population. That is impossible. So now, from relative risk, I can also calculate attributable risk. Attributable risk, I have a real simplified way of calculating it. I take the relative risk, in this case which is 5, I subtract 1, because 1 is the risk for being in the population. Then what's left over the total risk, equals the attributable risk, which means 5 minus 1 equals 4. That means 4 out of 5, or 80% of the risk, is attributable to the exposure. So one more time, you have to have well-defined criteria for cohort studies, or otherwise you create a bad selection bias. You're going to have the wrong people in your study. So you can overestimate or underestimate your numbers. Whenever you follow them forward, you look for incidence, which is new cases. You look for prevalence, which is total cases. And at the end, you calculate relative risk. Relative risk is the chance of getting the disease after you've been exposed over the getting the disease if you have not been exposed. So you look at the chances and calculate the relative risk. If you tell me the relative risk is more than 1, then my confidence interval plays a role. You say, well, how confident are you that that calculation encompasses or can be attributed or applied to at least 2 standard deviations, so 95% of the population. If your relative risk is more than 1, then both your CI numbers have to be more than 1. If your relative risk is less than 1, let's say you say the relative risk is 0.8, then both my CI numbers have to be less than 1. If they ever go across 1, there's been a flaw somewhere in your study. After you figure out a relative risk, then you can calculate attributable risk. That means how much of that risk is attributed to the exposure. You take the relative risk, in this case I used 5, subtract 1, which is the number we give to the general population, Okay? And then what's left, which is 4 over the total, it tells me the percentage of the risk that's attributed to the exposure. In this case, it would be 80%. So that's prospective studies. What about retrospective cohort studies? Retrospective cohort studies means you take a bunch of people and now you're going to look backwards. That means you're going to ask them questions about what happens in the past. Well, anytime you start doing a retrospective study, a different group of biases start to come in. The first and most important one is called a recall bias. Recall bias comes from the fact that people just can't always remember what happened in the past. So that means because memory deteriorates with time, you're going to underestimate, in most cases, your incidence or whatever the prevalence or problem or the exposure you're trying to figure out. So retrospective studies have a recall bias associated with them. So now when you're doing a retrospective study, you could just be asking questions to figure out the prevalence of something from the past. However, if you have a group of people and they already have the disease, they have a case, and therefore we call it a case control. So a case control study is retrospective in nature. What you're taking is a group of people who already have the case, i.e. the disease, and you're going to look back in history to figure out what exposure caused this disease. In other words, what you're going to do is ask yourself, what are the odds that what I'm looking at in the past is what's causing what I see now in the present? That's why we then call it an odds ratio. Odds ratio is calculated by, you look at the incidence of the disease, or rather the prevalence of the disease in the people who've been exposed to something you're looking at, versus the prevalence of the disease in people who live in the same neighborhood who don't have the disease. I mean, who were not necessarily exposed to the problem. And you want to see, well, how come these people got it and the other people did not, and yet they live in the same neighborhood? So to set up a case control study, you get the people who have the case. Then you create a control group. The most important thing is a control group must be a group of people with the same demographics, but they don't have the disease. Why does it have to be that they're in the same demographics? Because that way they could have possibly been exposed to the same problem. So now you're asking yourself, why didn't the control group get the disease and the case group got the disease so easily? So by looking at that, the difference in the prevalence in the two groups, then you can say, well, maybe that is the exposure. And when the odds show you a large discrepancy, then you say, well, then this probably could be the exposure. You can never be 100% sure of it. Even with the big study done on asbestos exposure, it was only 95% sure that this must be the exposure. So case control studies, you're looking for odds ratio. So that's the cohort studies. Then we have something called clinical trials. Clinical trials say you're going to intervene somehow. That means I'm going to do a trial where I'm going to give a medication and see what happens. Or I'm going to do a behavior modification and see what happens. All right, so clinical trials don't always have to be involving medications. So clinical trials can be single-blinded, meaning the patient does not know whether he is on the drug or not. But whenever you have a single-blinded study, then you have what we call observer bias. In observer bias, the doctor knows who's on the drug and who's not, and therefore he's more likely to behave differently with the people who are on the drug versus the people who are not. So you get a too big of a bias because it's going to skew the results. So that's why the industry standard is double-blind randomized studies. When it's double-blinded, the patient does not know if he or she is on the medication. The doctor does not know who is on the medication. And you can even triple-blind study where the company does not know who's on the medication. Now, when you do a double-blind study, this is where the pharmaceutical companies became involved. Because if I'm going to give pills to two groups of people and they not know who's on the medication, then that means your placebo pills have to look identical to the pills with the medication. Otherwise, if they look different in any way, then one group of patients will know that they're on a certain medication and is different from the other. So clinical trials, the best ones are double-blind, randomized studies. Those are the most believable and trustworthy. So a case study, again, I just like to review it again, just so you hear it again and again. A case study is just write-up of an interesting case. A case series, somebody pulls all these interesting cases and looks for a trend. A cohort study is when you have a group of people and you're going to have a defined criteria about who can get into this study and who cannot. Prospective says you're going to go forward in time. And when you go forward in time, you got to make sure you have the right criteria for joining, or else you have a selection bias. Whenever you go forward in time, you then look for new cases, which we call incidence, total cases, which we call prevalence, and then we calculate a relative risk at the end of the study, which means how much more likely are you to get the disease after the exposure than the rest of the population who don't have the exposure. And then after that, you can calculate a attributable risk, which means you subtract 1 from the relative risk, and what's remaining over the total equals the amount that's attributed to the exposure. Now, the other thing I mentioned is that when you have an relative risk, then you calculate a confidence interval called CI. The CI just says how sure are you that this information can be applied to 95% of the population, which is 2 standard deviations. And as long as your number does not go across 1, then you're okay. Meaning, if your relative risk is higher than 1, then your CI numbers have to be greater than 1. If your relative risk is less than 1, both your CI numbers have to be less than 1 as well. So cohort studies can be prospective, or they can be retrospective, means you're going to look backwards. A retrospective study can just be a survey about whether you took a certain medication when you were a kid, or whether you were bullied when you were in high school. That's a retrospective study. Now, if you're going to take a bunch of people who have the case already, then we call it a case control study, which is retrospective by nature. And for retrospective studies, recall bias is a big problem because people don't remember things clearly, so you tend to underestimate your numbers. With a case control, you take a bunch of people who have the case, then you create a control group, and it has to be people from the same demographics, so they had the same possibility of being exposed to something that's causing the case that we're seeing right now. And then we calculate what we call an odds ratio. What are the odds that what you are seeing in the past is what's causing the problem that I am seeing now in the present? Case control. Clinical trials can be single-blinded when the patient is unaware of the assignment, and double-blind when the doctor and the patient do not know. What about other studies? One is called a meta-analysis. A meta-analysis. A meta-analysis is when you pool a lot of studies that are small to create a large pool of data. Meta-analysis is great for rare diseases. By pooling a lot of data, then you can start looking for trends. You can't really call it a conclusion simply because you did not randomize those studies and you did not set up the criteria. All you did was pool studies that were done on rare diseases that are similar, and then you start to see what trend can you infer from the information. A cross-sectional study means you're going to randomly just look across a section of society, so to speak. This is a person who stands out in the corner and just interviews anybody who comes by. There's no entry criteria. Cross-sectional studies identify prevalence and incidence of problems, but never the etiology. You have to do a separate study to figure out the etiology. Longitudinal says you're going to follow them over time. And then observational says you're just going to observe what's going to happen, but you're not going to intervene. Much like, let's say, the Tuskegee observational studies on the epidemiology of syphilis. where men were injected with this spirochete, and they just observed to see what was going to happen. A lot of observational studies are done on the Army in the U.S. when they try different chemicals to see what effect it would have on men in battle.